Hi, I'm Renee Floric, and I am going to talk to you about clinical documentation specialist. I currently am a certified clinical documentation specialist, and I work for St. V's. Generally, a nurse or HIM professionals are clinical documentation specialists. A clinical documentation specialist analyzes patient record. They make sure that the information that is in there is appropriate and is there to better facilitate the physician's documentation so that there's a clear picture um, of this patient's story. At St. Vincent, we use a program called Clintegrity 360. It has an area where we can check on things, anatomy, when you're looking for where maybe something might be, maybe a specific tendon or bone that you can't exactly remember where it was because it's been a long time since you had um, pathophys or anatomy, um, also your drugs, abbreviations, that kind of thing. You can search any medications you want. In this case, I looked at NUR to see what it is, an anti-anginal, that it's a nitrate. You could also look up things like what kind of medications maybe you would use uh, for pneumonia, or if you wanted to know for Vanco, what kind of infections it may treat. There's also a place for coding clinics, which is the rules that we have to go by when we're documenting or reviewing a chart. If we need to ask questions, there are specific coding guidelines, and sometimes there may be differences, and coding clinics are there to help us with those coding rules that we may not be very familiar with. Here's the example of the work list that I use to help with my work for the day. It will have the pair, the admit date, discharge date if the patient has been discharged, the current working DRG, the current relative weight, the patient's length of stay, whether what day we should follow up on them, the nursing unit. It has a flag to let us know whether or not there's a clarification on this case or not. If it's not green, that means it's still open, that the question has not been answered. And if it is green, then it means that the question has been answered. Um, so it's final at that point. We also have the possible length of stay here, the possible weight, and the possible DRG. Here's any notes that we may put in our system so that we know what to follow up on. This is the sheet, what it looks like when we're looking for codes. It's the search sheet. Here I searched for pain to see what come up. This paper here will let us know that there's some information we can find about that. So if we click on it, it will then go to here and let us know that these codes are excluded from the pain DRG. Okay. Here is something that comes up when you click on that page or on the diagnosis code that says, hey, this is a sign and symptom. Let's go to the decision tree and see if there's not a way we can get out of the sign and symptom of pain. So here's the thread, and we go here to the important references task. And it comes up that there are signs and symptoms, official guidelines, and what the MDC 23 signs and symptoms is. Acute pain is considered to be a general symptom, so it's assigned to this MDC here. So what we want to do is, like, we want to ask a question to get this patient out of this sign and symptom. Here are some guidelines, and it shows you what you need to do, what a using of a symptom code is, whether it's acceptable for reporting purposes, and that kind of thing. Here's some other common signs and symptoms that we would also try to get a different diagnosis for. You don't want just cachexia or altered mental status. They're just signs and symptoms. Here's a scenario of a person who has pain, and the purpose of this clarification or query, the question we're asked is to see if it's an acute pain or a chronic pain to get the best treatment or the best diagnosis for this patient. For example, like this acute pain he's had for 10 months. He had a cabbage 10 months ago. So the question that the CDS is kind of coming up with is this chronic thoracotomy pain related to the cabbage? You know, it really doesn't seem acute even because he's had it for 10 months. So the indicator she gives is that the pain has been present for 10 months and it gets daily narcotics. He gets daily narcotics. The risk factor, he had a cabbage 10 months ago, and the treatment is that they're putting in this neurostimulator. So most likely this is more of a chronic pain and not acute. So one of the more common signs and symptoms that we see is altered mental status. So obviously, altered mental status is not the best diagnosis that we would want to have on our chart. It obviously shows that we may have people that come into St. B's that are just confused or altered, but we really don't treat them or find out their real diagnosis. So something that you might want to do is maybe see if they have encephalopathy or an acute confusion or dementia with behavioral disturbances. Those are real reasons for altered mental status. They are not signs and symptoms, they are diagnosis. So there are different types of encephalopathy. There's alcoholic, arteriosclerotic, hepatic for those that may have cirrhosis, hypertensive for those non-compliant patients that don't take their medications for their hypertension, maybe even post-concussional for those people that have been injured. Here are some of the clinical indicators that would help you determine if this patient has encephalopathy. The symptoms of encephalopathy are loss of memory or cognitive ability, poor concentration, subtler personality changes, lethargy, progressive loss of consciousness. Other symptoms that you may find as well. Here's a scenario where someone asked if maybe this was a post-concussional encephalopathy for a patient who was observed for 23 hours after falling and hitting their head, and they did have the diagnosis of concussion. Um, she's continued to maybe have some episodes of altered mental status, and the clarification was post-concussion encephalopathy related to a concussion 3 days ago requiring inpatient admission now. The things that they did were they treated the patient with a CT and MPO, and they did neurochecks every 30 minutes. Definitely a better diagnosis than altered mental status. All that does is gives us that she was altered. It doesn't give us the reasoning for the alteration. So we always want to try to get a more concrete, accurate, clear picture of why the patient has been hospitalized. So this is what the worksheet looks like when you have a clarification and when you don't. So different reasoning from than what we just went over, but this patient was admitted for hypertensive heart disease with heart failure. They also have a acute on chronic diastolic heart failure, and they have COPD. So right now, that current DRG is heart failure and shock without a CC or MCC. So it looks like there was a question asked about some chronic respiratory failure. The question will change the DRG to 292 and give it a CC or comorbid condition. It changes the weight and the length of stay. And the things you want to look for with the chronic respiratory failure, risk factors being chronic lung disease or COPD, and that patient did have that, as we noticed. The treatment, usually you want to look for like maybe supplemental oxygen, bronchodilator, steroids. You want to do once we've completed our chart and the patient's been discharged, we do what's called reconciling, which meaning that we check to see if the codes that we've come up with the questions we've asked match what the coders come up with, just so we have an idea of how we've impacted the chart on this admission. So I would do an advanced search. I look for the CDS, which is me. The encounter status is N for not reconciled. And if I have a coder to a coder, then that means that it has a final DRG by the coder herself. So here's how my advanced search would play out. I don't have obviously my account numbers or names just for HIPAA purposes. But I have the payer, the admit date, discharge date, the working DRG, the working weight, and the length of stay. Here, there was a clarification written on this case, and it was answered. And it looks like the possible length of stay changed to 5.7, and the possible weight in DRG were different. They were 1.7 to 371. Looks like the coder came up with the same DRG. So that's good. So that lets us know that whatever I, as the nurse, CDS found on this in this record, the coder seen the same, and we looks like we did have an impact on this chart because the question we asked probably what it shows here, it did increase the weight and the DRG changed. The unfortunate thing is that the possible length of stay that we have of 5.7 is still way lower than the length of stay the patient was here, obviously. It's not always going to be that way, but it does show that we impacted the chart. Same here. Looks like we had a working DRG of 193 with the weight of 0.9759. We asked a question, must have been answered, and everything was changed here. It looks like the weight and the DRG changed along with the coder agreeing. So we impacted the chart again this time, and that is the goal. We use the programs we do to help keep track of the important questions we ask, how we can make sure that the documentation in the chart reflects the severity of illness and risk of mortality of our patients and the kind of work that is being done in our department. This is a way to share with you how nursing and nursing informatics can benefit the hospital in a different way than what you're used to.